Hello and welcome to Yashoda Hospitals. I'm Pratyusha Chaudhary hosting Nursing Education and Training webinar series live on Facebook every Thursday at 3 p.m., bringing forth the most interesting topics for you. Thank you for joining us today. Stay tuned till the end for the expert panelist discussion. Also, you can post your queries in the chat section, which can be addressed at the end of the webinar. When we get the question of what are these chest tubes, what are the main indications, what about the troubleshooting? In case of troubleshooting, how a nurse can address the queries. So for all this, we have put forward our topic for today, evidence-based update on chest tube management. So without further delay, let me introduce you to the pros of today's webinar. I take the privilege of welcoming our expert panelist for the day, Dr. Vishnu sir, Senior Consultant Critical Care Medicine, Yashoda Hospitals, High-Tech City. We welcome you, sir.
Good afternoon, everyone. Yeah.
Also, we have one more pro for today's as a speaker. She's Miss Dorothy Sheila. She's a nurse educator at Yashoda Hospitals who holds more than a decade of clinical expertise and working as a nurse educator at Yashoda Hospitals now. I request you to start over the session and energize with your talk, Miss Dorothy.
Thank you, Patricia ma'am, for the introduction. Good afternoon. Good afternoon. I'm here from the education department to explore yet another topic of interesting or yet another interesting topic to discuss, that is ICD drain and its management. So in this session, we will be discussing what is a chest tube, what is ICD drain, what are the types of ICD drain, what are the insertion sites where we can put the ICD drain, and also the nursing interventions or nursing responsibilities in carrying the ICD drain. So we will start with talking about our lung. Our lung is covered with the pleural cavity or pleural space. It is further covered in two phases, visceral pleura and parietal pleura. So the visceral pleura is a sheath covering our lungs. The parietal pleura is between the sheath covering between the lungs and the thoracic cavity. So a chest tube is insertion of a flexible tube inside the pleural cavity, entering through the intercostal spaces. What is its function? The chest tube's function is to drain out excess of air, fluid, blood, and pus from the pleural cavity. Why intercostal drainage? There are some clinical conditions where the intercostal drainage or ICD drainages are indicated. One such condition is pleural effusion. The other conditions are pneumothorax, hemothorax, and empyema. Now the question arises, where do we insert the chest tube? The answer for that is some doctors choose to introduce from the mid to anterior axillary line towards the second and third intercostal space in scenarios of pneumothorax. And doctors may also introduce the ICD drainage from mid to anterior axillary line to fourth and sixth intercostal space in conditions of hemothorax and effusion. So we will see what are the types of ICD used in our clinical practice. So to start with, it is the single bottle, then we have the 2 bottles, and also we have the 3 bottle drainage systems. Single bottles can be used in single drainage system, example, when we have to drain the pleural drainage. And the second, the 2 bottle and the 3 bottle drainage systems are used in conditions like mediastinal and pleural drainage, mostly seen in post-CABG cases. The additional third bottle is used when you want a controlled suction to remove the excessive amount of drainage. I hope I am clear until now. So we will come to the important part. What are the nurse's responsibilities in managing the patient with ICD drain? First and the foremost is checking of the vital signs, which is very important. A nurse is advised to check vital signs every 15 minutes for the first hour, every 30 minutes for second hour, and every hourly following with that. A nurse should also not forget that pain is an important vital sign and pain assessment should be done, and pain management also is important in this scenario. The nurse should notify the doctor if there is any sudden onset of dyspnea. Coming to the checkpoints, to make it very simple and simplify the process, we suggest nurses to check from the insertion site, tubing, and the draining bottles. So what should we check at the dressing site? The dressing site should be checked for any oozing, any signs of infection, or the dressing soaked with any leakage. When you come to the tubing part, you have to check for the column movements. And when coming to the drainage bottle, the nurse should see the amount of the fluid drained or the volume of the fluid drained. The nurse should notify the doctor if the drain is more than 200 ml within 1 to 2 hours. And the color and consistency also matters. If there is any fresh blood or new frank blood, the nurse has to notify to the doctor. So troubleshooting is very important in ICD care. So the nurse should identify the problems and act immediately. Immediate action is very much needed in these scenarios. Scenarios like tube kinking or pressure, the nurse should know whether the tube is placed properly in position, whether the patient is lying down on the tube or any other obstruction. If the nurse finds any mucus plug, she is advised to milk the tube, and if the thick mucus plug is noticed, you have to milk the tube and try to remove out the mucus plug. Second scenario is continuous air bubbling in the bottles. The nurse has to troubleshoot for air leak. If there is a intermittent bubbling, that means it is a normal air leak. And if it is a rapid bubbling without any air leak, it is considered as abnormal and emergency. So what should the nurse do? She should check the insertion site, tubing, and the drainage bottle in order to verify from where the air leak is coming. If the leak is from the bottle, she has to pinch to the insertion site at least for 10 seconds and tighten the bottle of the lid, which will solve the problem of leakage in the bottle. Coming to another troubleshooting part, which is dislodgement or pulled out, which can be seen. In this scenario, the nurse should not panic. Okay, if it is an accidental removal of the tube, the nurse should seal off the insertion site with a sterile gauze and try to remove the ICD drain. Okay, while removing, she has to encourage the patient to cough and deeply exhale and quickly remove the tubings and arrange for new insertion if it is indicated or advised. And a chest X-ray will help. Another scenario where the nurse has to troubleshoot is absence of column movements. In this, you should know why the column movements are absent. Maybe it is because the lung fully expanded, maybe it is because of the air leak or kinked tube or obstruction. So as I said in the previous slide, that the nurse should check for the insertion site, check for the tubing, and check for the drainage bottle, inform the doctor immediately and treat accordingly. Next, coming to the important part, nurse's responsibility in emptying the drain. So it is a major task for the nurses to empty the drain. So when we see the steps of emptying the drain, step 1, she should arrange for a new bottle drain that is already pre-filled with 100 ml NS. Then she should clamp the tube and disconnect the tubing from the bottom, not from the insertion site. Thirdly, she should maintain the suction between 25 cm to 50 centimeter of water suction. And last, she should reconnect the tubing to the bottle and unclamp the tubing. Here, the nurse should be very cautious not to clamp more than 10 seconds because it causes tension pneumothorax. And it is evident that according to BMJ journal published, a survey was conducted to establish the current status of chest drain management. It consists of chest tube insertion, day-to-day care, removal of chest drains. This study showed that following standardized protocols of insertion as well as managing the chest drain can reduce unnecessary complications and can reduce the stay of the patient in the hospital. Thank you.
Thank you so much, Dorothy. It was an amazing presentation, and it was a crisp presentation which you have given about the chest drain management. And the panel is open for the discussion now. I request all the participants to kindly post your questions in the chat section so that we can address at the end of the webinar. So, can you unmute, sir? Vishnu, sir?
Before taking up the questions, I would like to add few points actually.
Yes, sir.
So she covered almost all the troubleshootings and all those things because you people are not, so you should not know how, where to insert, when to insert, what to choose and all those things. So I'll just briefly introduce. So we know the main indication for ICD are 4 things. She already pointed that. So like air in the pleural space, okay, fluid in the pleural space, whether the hemorrhage in the pleural space, or some whatever. So these are the main indications for the placement of ICD. So generally we use the safe triangle. Okay, whenever we are inserting the chest tube, it's the safe triangle is nothing but, so anteriorly we have pectoral muscle, posteriorly we have a dorsalis muscle. So that forms the apex will be at the base of the axilla, and your base will be a line drawn, imaginary line drawn at the level of the nipple level. So that is the safe area where we insert. So generally we use 4th or 5th intercostal space to place the chest tube. So in pneumothorax, when we are inserting, we direct the tube anteriorly and superior. So she said we inserted to a 2nd and 3rd.
Okay.
For a fluid in the space, in the same space we use, but we direct the tube inferior and posterior for any fluid in the lungs. Okay, that is regarding the insertion. Okay. So next, we have to secure suturing. So because why this is used? Because we'll try to escape the bundles. I mean, intercostal vessels and all those things, bleeding chances will be less. Okay, these are all things. So next, what you need to know is troubleshooting. Welcome. So how to manage the chest tube first? So most of the times, as she said, after putting the ICD, we use a single bag when it is only pneumothorax. Most of the times. Okay, we'll have a water seal. The water seal prevents one-way movement of air. So water seal helps. So the pneumothorax, I mean the fluid in the pleural space will come into the fluids and bubble out. So atmospheric air won't go in when the patient tries to breathe in, because during respiration, what happens is there will be negative pressure created in the pleural space. This water seal prevents only one way out. So there will be no air entering into that. So we should make sure that the column is filled. Okay.
Yes.
It is specified. So that you need to second. So when we are using 2 bags or 3 bags, most probably 2 bag or 3 bag machines are used when there is a hemorrhagic fluid or fluid in the pleural space, thick fluid, where we need some suction. Because if you use a single bag in a hemothorax or pneumothorax, what happens is the water seal raises.
Yes.
So what happens after a few minutes, when there is a massive hemothorax, the bag is filled. So the air from whatever the fluid from the lung won't come out. That is the reason we should use 2 bag or 3 bag. Okay. So when we are using 2-bag, 3-bag, where we attach to the negative suction system. Okay. So in our system, we should be very careful when you are connected to the negative pressure. The pressure is -10 to -40 centimeters of water.
Yes.
So most of the times, people I've seen using centimeters are.
Yes, people doesn't know how to. Yes, yeah, exactly. Need to
So
be
that high pressure, what happens is the tube itself collapses. It causes so much of negative pressure in the lungs. It causes intense pain and the collapse of the tube. So it won't be affected drainage. Even if you keep less pressure, the purpose won't serve. So we have to make sure that it is between -10 to -40. Okay, or exactly, sometimes you have to adjust the pressure in such a way that the lung is fully expanded. So the main purpose of putting ICD is to remove the fluid and the lung, to keep the lung open. Okay, so in an X-ray we can check so whether the lung is fully opened or not. The other things is, I want to add few more points, is troubleshooting at the site. As likely said, we have to daily observe the site of incision for redness, infection, all those things, because 1-2 days when a post surgery where we remove it, but so a few people might require where they're having bronchopleural fistula or some other things, they might be requiring ICD for a longer duration or empyema, so all those things. So there you have to check for the local site infection and inflammatory signs and all those things, and the dressing has to be changed every 48 hourly or whenever it is soiled or soaked.
Great.
Okay. The other thing I want to add is like we have to make sure that the air seal is properly filled, like 100 ml, whatever the bag says. The third thing is kinking and blocking. Whenever we have to check for the air column movement. When there is no air column movement, there is a problem. Either the lung has completely expanded or there is a problem in the drainage system. We have to check that. So if there is completely expanded, it's okay. If it's not expanded, we have to check for any kink or block. And every time whenever you are seeing that, you have to see that the bag is below the chest. Whenever you are hanging the tube.
Okay.
Okay, the bag.
Below the chest.
Below. It has to be below. It should not be at the level or above. So for a pneumothorax or a bronchopleural fistula, never try to clamp the tube and leave it there.
So there is one more question from the audience stating about the same clamping. Do we need to clamp the ICD during transportation of any procedure, irrespective of pneumothorax or hemothorax?
That's what I'm saying. Coming to the clamp, generally what we say is, whenever if the bag is in the gravity dependent, no need to clamp. Okay. So, but when you are trying to push the make the patient move from one bed to the other bed, if you are maintaining that gravity dependent position, there is no need to clamp. Or else, if you are keeping by the side or above the patient, that time that for a few seconds you can clamp and unclamp it after keeping the position. But make sure that the clamp duration will be not more than that. In a bronchopleural fistula, we should be very careful during the clamping. So because even if you briefly clamp for even for 10 to 15 seconds, the chance of developing tension pneumothorax will be very high. Okay, but temporary shifting, you need to clamp. And most of the times we have seen that air vent is plugged in. Whenever you connect it.
Yes.
Now the bag, it has to be open to the atmosphere. You never should clamp the tube. So these are the things. Next, milking, when there is clots or blocks, we should be careful when we are milking. There are two techniques. We can use a milker. When you are milking, you should make sure that your other hand is pinching at the side so that it won't pull out when you are milking the tube. With the other hand, you can use a milker to remove the clots in the tube. The other thing is we can flip the tube for 360 degrees and see. These are the two techniques we use actually. Next is coming to the pressure. I told you -10 to -40. Okay, I think these are the points I wanted to add. So anything, I'll take that.
Sir, apart from this, what would be the, as you said later, there are troubleshooting areas. So as red flags, sometimes suddenly it has been, the tube has been dislodged from the site.
So what would be the so there are two things. Is the ICD is dislodged at the clamping side of the bag or at this? So there's nothing to clamp. So nothing to worry immediately. So when it is clamped, when it's disconnected at the connectors, so if you have a new bag, immediately try to connect a new bag, or else clean it with the sterilium and immediately connect and get the new bag and do that. Okay. So if you have a clamp, you have to clamp it immediately. clamp the test tube. If you have a clamp, you have to clamp that immediately. If you
Mhm.
have a new bag ready, you can use the new bag. If you don't have a new bag, you just clean it, the tip and all those things with Sterilum, connect it and open the clamp and get the new bag and change the bag.
In case if it has been disconnected from the chest, then
Then
from the
what you have to
insertion
do
side.
is, now immediately what you have to do is take a gauze piece,
Mhm.
keep the gauze piece there, and close it with the plaster and call for help. If it's a bronchopulmonary blister, you have to use like a 3-side. You have to cover it, open it to the one side so that they won't form a
Tension pneumothorax.
tension pneumothorax. If it is a bronchopulmonary blister, for other things, you can just keep a gauze and close it. And we can come and put another test tube. The other thing is, and the drain, when you're calculating the drain, so you have to see for the flank blood is coming or not. So 1 hour, if it is 300 ml, you have to inform. Or 200 ml every hourly for 2 hours, you have to inform. The other thing is 100 ml per hour for 3 hours. These are the red marks. Whenever the drain is there, you have to inform and you have to take care that there is serious bleeding going on inside. The patient has to be taken for re-exploration actually. So she said around 100 ml, 200 ml per hour. That is not the. These are the guidelines. 300 ml in 1 hour, 200 ml per hour for 2 hours, 100 ml per hour for 3 hours. These are the red flags where we need to address the bleeding. There is significant bleeding going on in the chest.
Yes. So there is some question from Amu Angel, but sometimes doctors advise night ICD clamp and next day X-ray so that the time any problems, sir.
It's only to check. It's only to check whether the lung is expanded or not, completely expanded or not. So no need to clamp overnight and see.
Yes,
Not 2
true.
hours, it is more than check. So no need to clamp overnight and check. Okay.
Sir, by the take-home message,
Yes.
so what are the top 5 tips you wanted to give for the nurses that they need to monitor completely?
Monitor site checking, infection, inflammation. Second, water seal, adequate amount. Pressure, make sure that it is below -10 to -40. Okay. So check for air column. Whenever there is no air column, it has to be informed. Next, the third thing is, that's 5 points.
Yes,
Anything
sir.
you want to go? Yeah. These
Sure.
are the 5 things I think should take almost 90% of your ICD current every time. So you have to check for the position of the ICD. Just accept.
Great. Thank you so much, sir, Vishnu sir, and thank you, Dorothy, for the expert topic that you have chosen and bring forward for the audience. And really, it was a very crisp presentation, but seriously, we have come to know the top prioritized topic, means the points that we need to keep it in mind when we are trying to monitor a patient on with chest tubes. So for the final note, we are going to come up with the most interesting topics further for the next Thursday also. Please do stay connected. And in case if you like our webinars, please do share and like on our Yashoda Facebook page. And I would like to thank our director of Yashoda Hospitals, Dr. Pawan Gorukanti sir, for giving us this platform for nursing education to explore the knowledge of nurses around the globe. And our DMS, Dr. Lingay sir, and our AVP, Dr. Amar sir. Last but not the least, our GM Nursing, Vimla Prasad Bam, and also my whole nursing education team, and Mr. Pawan for digital marketing. Thank you so much, audience, and please do connect for the next Thursday with a more interesting topic. So please do stay tuned for us. Thank you, sir. Thank you.